All right, we got everybody. We streaming. We're doing everything. Everybody's up live. We're zoomed in. Dr. Boyd Haley, can you hear me?
Yes.
All right. Dr. Stanley, can you hear me?
Yes, I can.
All
How
right.
are you all?
We got everybody there. Okay, I need questions. Anybody have questions for the speakers? All right, we got one over here. All right, go ahead and stand up so they can see you.
Hi, I have a question. I think it was Dr. Stanley mentioned a vitamin D test that was done in the office. I don't know if we have that available in the United States or if Dr. Jaffe could also explain that to us. That'd be something that we would like to be able to do.
Yeah, hi, thanks for your question. First of all, I'd just like to say thank you to everybody at the IAOMT for having me. I'm sorry I couldn't be there in person. You know, the world's changed quite a bit, and this was put together with a monumental effort, and I'm just very grateful for everybody for having me, and I'm very, very grateful, and I hope to see you all in presence at the next one. So regarding the vitamin D machine, it costs about $1,200 US. I believe that it is coming to the US very soon, as the company that distributes it is also the same one that distributes the photobiomodulation machine that I presented. So I'm going to, as soon as I understand who has it and who distributes it, I believe it will be Biotech Dental, this French company in the US. And as soon as I have that data, I will share that with Amanda and the team at IAOMT so they can share that with you guys. It takes roughly 15 minutes, a finger prick of blood, and it's like a rapid COVID test. So it's a very simple process, and the results, we've done double tests against proper blood tests from labs, from several labs, and it's incredibly accurate. And it's just a great way to start your relationship, your surgical relationship. I mean, we're now doing it just with everybody. So my clinic, we do normal family dentistry, we do every type of dentistry. And if you're going to be in the healthcare sector, so if you're going to transit from being just a dentist to also a healthcare provider, vitamin D is just like that magic entry-level hormone that is just, when you have your levels over 35, 40, it just changes everything. So we have a nice poster on the wall of every office that explains the importance of this. So we don't have to explain it all the time, and everybody gets tested. We charge $35 for it. I mean, it's not that much, and almost instantly, I mean, we've discovered that about 70 to 80% of all adults have low values, even living in a sunny country, and we also have the supplements that we provide to them. And I was very serious when I said if their values are lower than 30 and we're placing implants, we cancel the surgery.
All right, does that answer your question? All right. Who else has a question? Somebody raise their hand. Because I've got one. I do have one from an online viewer right now. All right. This is from Marsha Rutledge, and it's a question actually for you, Dr. Haley. All right. Can you hear me okay?
Yes.
All right. The question is this. Can patients who still have amalgam fillings in their mouth use Nbmi, or does this treatment happen after amalgam removal?
You can. A lot of people have used that. They have amalgam fillings in their mouth. It doesn't change anything. I mean, but if you want to detox your body, you know the amalgams are constantly giving mercury vapor to your bloodstream, and so you want to get the amalgams out. But no, this compound, we haven't found a single situation where this compound is potentially toxic, and it will bind the mercury in the blood. In the cells. You know, it's the reason I gave that extensive presentation about the radioactive Nbmi, or compound we made with and without treating rats with and without pre-injection of mercury. The compound just you know, goes about its merry way, and it doesn't seem to do anything wrong or cause any problems. So you know, I would suggest, if I had a mouthful of amalgams now, or met somebody and said I'm sick and I got a mouthful of amalgams, when should I start taking Amerimed or Nbmi? I would say yesterday. I mean, it's good to take if you have amalgam fillings. It just takes the mercury out of your body, no matter where it comes from, or when it got there. So, no, go ahead and use it right away.
All right, great. Thank you so much, sir. All right, do I have any other questions within the room?
When will it be available in the United States?
Oh, good. Dr. Margolis would like to know what the status is of Ermanix. When will it be ready here? Do you have any idea when the FDA is going to let it loose?
We just submitted an information package of 132 pages to the FDA, and we have a meeting. They're evaluating it now, and we have a meeting with them on April 16th when we'll have a better answer. And I would give you an answer about when, but the FDA is, I mean, there's no way you can outguess them. But we're close. We have fulfilled every obligation or and we've done every experiment and study that they've suggested we do, plus a lot of extra. And I think that radiation study showing that the compound does not build up in any tissue, with or without mercury present. You take Nbmi, it all gets out of your body within about 72 hours. You can hardly see any of the radioactivity left, meaning it's not building up in any tissue, which was their major concern.
All right, thank you, sir. All right, I have another online question. This one is actually it's a two-part question. It's directly towards you, Dr. Schallenberger. All right, this individual would like to know, it says, how effective are ozone saunas compared to other forms? Just click it up. There's a little switch with the red button on top there.
That's okay. That's a question that we get a lot, and unfortunately, it's pretty hard to answer the question because there's no head-to-head study, so I can't quote any really good head-to-head studies. I will say that the American Academy did a 5-year survey. It wasn't any kind of rigorous study, but it was a 5-year survey, and basically it was looking at safety, and it was looking at efficacy. And then we looked at a safety to efficacy ratio. And so we rated everything on those 3 categories. And so number 1, so we looked at saunas, rectal insufflations, ozonated saline, direct intravenous gas injection, and MAH. We looked at those 5. And we had to stop the direct intravenous gas stuff after about 2 or 3 months, secondary to complications. But we did get some data on that. All the other ones, no problems. Interestingly enough, in terms of efficacy, MAH was, that's the blood treatment, was tied with rectal insufflation in terms of overall judgment for efficacy. In terms of overall safety, saunas were heading the list on safety in terms of side effects, complications, anything. I will say that overall, the side effects were pretty much minimal across the board, except with the direct IV injection technique. That one had some fairly significant side effects. Other than that, the side effects were pretty low on everything. But saunas did amazingly well in terms of, in fact, they led the safety to efficacy ratio. So all in all, in my practice, we've got everything there. We do everything. We do the saunas, do the rectal insufflations, do colonics with ozone, and of course do MAH, and then we do ozonated saline. My favorite, the one I think is the most successful and my go-to, is always MAH. I rarely go to something else unless, I'll go to a rectal insufflation if the treatment is centering around treating a colon or intestinal disease or hepatic disease, because those peroxides are going to go straight to those areas. Other than that, and you can combine them too. You can combine saunas with MAH. We do that all the time. Have somebody come in, get a sauna, maybe the next day get an MAH, maybe the day after that get a colonic. It depends on how aggressive you want to get with your detoxification. But I will tell you from my experience and from the experience of some of other American Academy members who only do saunas, that sauna is pretty darn effective. Especially it's immune stimulating, but it's also detoxifying at the same time.
All right. Thank you, sir. Second part of this question here, just while we're on it. The questioner actually is asking your opinion when comparing topicals like ozonated water, ozonated oils, or potentially ozonated essential oils, and how they potentially can benefit patients as well.
Yeah, I don't know much about ozonated essential oils. I think that might be a little concerning because when you ozonate something, you're going to break up all the double bonds in there, and I'm betting a lot of the active ingredients in essential oils have some double bonds in there, and you may be destroying some of the active ingredients. So I don't know that's an altogether smart idea. If I wanted to do essential oils, which I do sometime, I'll like take an ozonated olive oil, for example, and throw a little frankincense in there, mix them together, but I won't ozonate the frankincense per se. And so we have mixed things like that together. If I'm putting ozonated oil on the gums, which is a fantastic treatment for periodontitis, it tastes horrible, but you can take some mint oil, some essential mint oil, and put it in there. It makes it a little bit better. Lemon balm's a good one for that one too. Yeah, so topically speaking, we'll do two things. Probably my number one. Let's say we're treating an ulcer, a diabetic ulcer, a varicose ulcer, something like that. My number one treatment is going to be to put the gas directly on the lesion. Usually we do that with a bagging type of technique where the hand or the foot is in a bag, and then we're inflating that with ozone gas. Sometimes you can take a little cone type of deal, put it over the lesion, and just flush the lesion with gas. And it's just astounding what you can do with that with ulcers, failure to heal wounds, just really amazing. And we'll do that like every day, maybe even twice a day for half an hour. The whole procedure is described in the applications book. And then after each one of those treatments, we put ozonated olive oil on, and then when they go home over the weekend, I have instruct them to dress it with ozonated olive oil. So that's normally the way I'm going to go that way.
All right. Thank you, sir. Questions from the room? Anybody else? Yeah, we got one back here. Okay. Hold on. They can't hear it online. Stand up so they can see it.
Also for you, Dr. Schallenberger, the MAH, like you do it versus like what's sometimes called the 10 pass, where you do 10 times.
Yeah, so what the 10 pass is it's a way of delivering ozone under pressure. So there's two things that happen when you do that. Number one, the blood gets sucked out into the bag and pushed back in from the bag into the patient very quickly. So normally with the gravity drain method that is traditionally used, it might take you to do like a 12 milligram dose. It might easily take you 30 minutes to 45 minutes to do a 12 milligram dose. With the hyperbaric method, the so-called 10-pass method, each 12 milligrams can be done in the order of 5 minutes. So if you wanted to give the patient a big whopping 75 milligram, 100 milligram dose, it'd take you all day to use it with the traditional MAH drip, but you could do it with that 10-pass type protocol in 45 minutes. So that's one thing. The other thing about that protocol is it's pressurized, which means when the blood goes into the patient, there's going to be a lot of oxygen release. So that extra oxygen in tandem with the ozone seems to have a kind of let me just say, a special effect. I don't know that anybody really knows what the effect is. And thirdly, I would say, there's just a sort of a logistical advantage to the 10-pass machine, which, by the way, is what? It's something like $15,000, $20,000 to get that, as opposed to, the ozone machines you can get for $2,500 and that don't have the ability to do this pressurized thing. So you spend a lot of money for it. But let's say you have a fairly small office and you want to do a whole lot of patients in that office. You could get a 10-pass machine and even just have one chair and just keep moving out of that chair very quickly. So it has an advantage that way. Dosing in medicine, dosing is sort of the art form in many ways. The other art forms are, figuring out what to treat or how to treat, but there's always the dose. The dose is critical. Sometimes a dose is too large, sometimes a dose is too small. These are biological stimulating things, so it's not like more is better all the time. I'm a little concerned that there's a lot of people, since this 10 pass thing, which normally uses large doses, like a full 10 pass is going to be in the order of 120 milligrams. Now, if I tell some of my European colleagues that I'm giving 120 milligrams of ozone to a patient, some of them are going to fall on the floor and have a heart attack. They're just not going to understand that, and they're going to say, well, you're just American, and that's why you do that stuff. There's a little bit of some reality to that. So I would just encourage anybody that when you hear about these 10-pass things, take them with a little grain of the salt. There's actually no published data on them whatsoever. More is not always better. But I have the machine. I have 2 of them, and they're very useful in many applications. Just if you get one of those things, start off with like 1 pass. In the office, I will tell you this. If I decide the situation is acute and it's urgent, and I want to really push the dose, which is what I can do sometimes, you know, I don't immediately go to 10 pass right away. I don't go to the 120 milligram dose right away. I might go to a 25 milligram dose and see how they handle it, and then come back the next day or in the afternoon and do another 25 and sneak up to that 10 pass. But you have to be a little careful if you're going to just jump right from a new patient, bang, go straight to a 120 milligram dose. There's some concern there.
Okay. I have another online question. This is actually for Mr. Augustin. Okay. The viewer wants to know, any chance we can get an example of a release regarding refunding money to a patient? Because she says, usually we are told if we refund the money, we accept our fault. It would be nice to have the proper wording.
There's no question that you can get a copy of that, and I can get one to this person if they want me to. I can do it. I'm going to be back in Naples, Florida, and I could do it this week if they want a copy of one, yes.
All right, so contact you directly via the email?
Right,
that you
would
listed?
be best, and then I could get back to them. And there's no question that you can do a release without any admission of anything. And in fact, I recommended, as I said in the talk, that you do it in a way that you say, in fact, nothing in fact happened wrong, but for various business purposes, you're refunding the money. Absolutely, it can be done.
All right, thank you, sir. All right, other questions? Yeah, Waz got one? I have one for Dr. Haley real quick while I'm going to take the microphone over to him. Boyd, do you have any experience? You mentioned with Nbmi that you're pulling out other metals like iron and copper from the body when you're taking the Nbmi. Have you had any instances where you've actually created some depletion of those minerals within patients that could cause a problem, like deficiencies?
What I can say is that we have done research on animal models of hemochromatosis, where we could, where the animal builds up iron in its body and in its brain, and it slowly becomes demented, loses the functionality of its limbs, lays down and dies. And if we give that animal Nbmi, it didn't die. And when we looked and sacrificed it and looked at it, it totally removed the iron, lowered the iron in all the compartments of the body, including the brain. And in the brain, it totally eliminated the oxidative stress markers to a level lower than what you found in the control animals. I mean, those don't get sick. So, yeah, we know, and we've done that. We did a study, which I presented partially in this my talk, on thalassemia, which is an iron overload. And we gave this to people who would build up iron due to the fact they have to get blood transfusions on a regular basis. And of the 8 that took the compound, the average iron increase was a -3%. So there's no doubt the compound, if you test it in the laboratory, it binds iron also very tightly. And so the compound is binding, but does bind iron, and seems to deplete its toxicity in the bodies every time we've tested it.
First of all, I'd like to thank all you guys for doing a really excellent job and bringing us such great information. This question's for Dr. Jaffe. Currently, I've been doing the liposomal glutathione-based detox protocol for myself and suggesting to my patients, but I'm very interested in learning and looking at the penicillamine that could you briefly describe what that would look like? I'm doing the glutathione protocol. I tell them for 1 to 2 years, and how long and what that would look like. Thank you.
Well, in regard to the D-penicillamine, it's a 3-day period. You collect a 24-hour urine on the second day. It's 35 milligrams per kilogram in 4 divided doses, which is 17.5, I think, per dose. But please read what we will send you if you email me at rjaffe at rmjholdings.com or any of my emails, rjaffe@perk.com, rjaffe@elizaact.com. We'll get you the details, and please, if you would, give us a call to make sure it was clear, because it would be helpful and synergistic. In regard to glutathione, you can only build glutathione inside the cell. When we take supplemental, even intravenous glutathione, it does not get in the cell. That's not an opinion. That's a well-confirmed fact. Now, when you give glutamine, you are giving some, when you give glutathione, you are giving some glutamine and glycine and cysteine. Those are the 3 amino acids of glutathione. You only build glutathione in the cell, and Alton Meister and others showed many years ago that the best way to build glutathione in the cell, both new synthesis and recycling and preservation, is enough ascorbate. So you do the C-cleanse, you make sure they have enough recycled glutamine, you make sure they have enough sulfur amino acids, like from the GGOBE, garlic, ginger, onions, brassica sprouts, and eggs, sulfur-rich foods. And you correct their magnesium deficiency, which you will confirm with the first morning urine pH. Because without an alkaline, magnesium-rich, energized environment or milieu, everything else is only marginally helpful. So we have looked and found that we can build glutathione in about 2 weeks by giving the precursor amino acids. But every study that I know that has tried to look at whether glutathione can be taken up, say, from the gut or from the blood into cells, confirms that it doesn't. Was that helpful? Okay.
All right, we have another question for you, gentlemen.
Again, I'd like to compliment all the speakers and thank them for all the great information they provided us today. It's an awesome day. Thank you so much. Dr. Jaffe, this question is for you, and we didn't really address it today, but could you talk a little bit about the NAD and the role NAD has in your protocols?
Oh, sure. Now, NAD, nicotinamide adenine dinucleotide. See, I really am a biochemist. NAD, very important. I think what you're referencing, my friend, is that there was an open-label NAD study done at Georgetown University that looked very favorably at NAD when a secret sauce was added, and the secret sauce turns out to be ascorbate. Now, NAD is part of the electron chain. Forgive me, but I'm going to be a little technical for a moment. You start with the electron liberated from the 2 position of the triglyceride. It is picked up by tocopherol and selenomethionine, transferred to ascorbate, from ascorbate to glutathione, from glutathione to NAD or FAD, and then that same electron goes into your battery mitochondria, goes through the cytochrome transduction, and the ATP that comes out is the energetic product of the original electron from the triglyceride in the membrane. So NAD is in the middle of all that, muy importante. But if you follow our protocol for the alkaline way, the body will have plenty of NAD and FAD. And I will mention that Dr. Joe Belanti, friend and colleague who did that open label study, then went on to have a funded double-blind placebo-controlled trial that failed. And it turns out, in my opinion, that Joe Belanti is a healer, and I would say that in his presence if he were here. I think he helped evoke their healing response. So we do have to be careful about promising open label studies, however promising they look. There is a reason why we need to do, quote, blinded studies.
All right. Any other questions in the room? Oh, we got one more over here. All right. I'm running again. I do have one more. We have time for a few more questions here. I have one more online that's kind of in the queue. So we'll start here.
Hi, I have a question on ozone on ear insufflation, if you have any studies or how effective it is. Thank you.
Yeah, there's not much on that. I will say that there's a fellow named, well, maybe he doesn't want to be named. Anyhow, there's a dentist, of all people, who has seriously looked into this and conducted some studies and presented some information at the Academy. And he's got some very interesting case studies. He's going to be there in May again, talking about, I know he's done some herpes zoster. I think he's going to have a heart failure case and stuff that's kind of really interesting. And he always presents good data. I would have to say my experience with it extremely limited. And he's got some theories. I was just talking to him the other day. He's got some theories on why it is that he's seeing these kinds of very interesting results, like flus and colds. He's got a few of those type of stories. That's all I can say. I can say I've done it. We do it on a fairly regular basis. I can say it doesn't help tinnitus, unfortunately. And I can say it's basically without side effects unless you overdose the person. And, ozone's an irritant. If you give it too much, you're going to just irritate things. That's all I can say about that.
All right. Here's a question for Dr. Haley, another online question. The question is as follows. For folks who don't have access to the Erminex product at this time, would other forms of sulfur, such as NaC or perhaps MSM, be useful?
They're useful, but they're just not nearly as effective. We've done a lot of comparative studies with N-acetylcysteamine and other reducing reagents, and nothing comes close to Nbmi because it not only is a very powerful antioxidant, it chelates the toxic metals and it eliminates the toxicity almost immediately. So.
All right, thank you, sir. All right, anybody else in the room? Well, okay, I'm coming. Hold on. Gonna make me run. Well, this is called social distancing running. Come on. Not gonna make you stand in a line this year. Next year, maybe.
Okay. Hi, Dr. Haley. We miss you badly. And my question is, do you think, due to so many people having implants, do you think that it's also going to be a chelator for titanium? Because recent studies that we've been looking at, it's showing that titanium nanoparticles are just all over the place with these implants. Thank you.
It could be. But I have no data to support my accusation. And as most of the speakers will attest to, we have to be very careful to separate what we think from what we know. And I don't know that, but it's a possibility.
All right. Anyone else? Go right ahead. Is it not working?
Okay, there you go. So all that glutathione I'm injecting intravenously, number one, where's it going? What's happening to it? It seems to be doing something clinically. And two, is the glutathione redox balance a signaling system that signals things to happen biologically?
Well, the second question, glutathione is part of redox signaling inside the cell. Glutathione is not present in large enough amounts in the blood or plasma to have a significant impact. In regard to your and many of my colleagues' use of glutathione, I again say that the way to build glutathione is with the building block amino acids, along with enough magnesium and ascorbate. It is the least expensive, most safe way to do something. Now, your point, Frank. You're a careful clinician and an observer. You said to me, it's doing something. I don't doubt it's doing something. What it might be doing is complexing with some of the schmutz, which is a technical term, in the gut. What happens to the glutathione? I can tell you for sure what happens to the intravenous glutathione. It first oxidizes to glutathione disulfide. So you go from 3 amino acids to 6. Still pretty small. You'd think that could get into the cell. But there is a very important self-regulating reason why cells exclude anything over 2 amino acids. So 3 and above do not get into the cell because they would dysregulate it rather than re-regulate it. And what I learned from you is we want to restore regulation. We want to restore physiology. We don't want to force the body because that will irritate the process, the system. So yes, I'm in favor of building glutathione, but I've been doing it for 30-odd years, the way Oltenmeister and other people taught me, including Albert Szent-Györgyi, and it works. You can get recycled glutamine into cells in adequate amounts. You can certainly get glycine in. You can certainly get cysteine. Now, I don't use sulfur amino acids except rarely in supplements. You get plenty of sulfur from garlic, ginger, onions, brassica sprouts, and eggs when they are a staple. And here I'm quoting Thomas Jefferson. Make condiments into staples and staples into condiments, and you'll have a healthier, long life. And if you translate that into English, what he's saying is more of the garlic, ginger, onions, brassica sprouts, vegetables, fruits, and, those low on the food chain, healthier, nutrition-dense items, and less of the things that we actually consume at rates that are historically staggering. Most Americans eat enough empty calorie sugar in 1 week to equal the amount that our grandparents ate in a year. When we talk about a better diet or a better supplement, my opinion is that there needs to be some evidence and not just opinion. I have a lot of opinions. We have, as Dr. Haley correctly says, much less fact and evidence. But in some cases, it does take a long time for a good idea, like can't I just swallow my glutathione? It's only a triamino acid, etc. I'm sure you have observed, Frank, and I have, things that were very interesting. We thought there was something real, and then we took it apart and tried to study it carefully or have someone else get the same results that we got. And then we move on to something else because, and here I'm going to quote IAOMT. IAOMT was the head of neurosurgery at NIH. IAOMT created the Ommaya reservoir. He's a big deal in neurosurgery. IAOMT did a study at NIH, and the results were so spectacular that he had Duke repeat the study. Now, colleagues at Duke used exactly the same protocol, exactly the same time, exactly the same anesthesia, okay? They did not get the same results. So then Ayub went back and he looked at who was the surgeon. When he was the surgeon, the results were spectacular. When anyone else followed the Ommaya protocol, the results were okay. So it does turn out that who holds the knife is very important, in my opinion. And I will say that I knew Ayub well enough to believe that he, like you, had the gift of healing, and that was part of, along with being brilliant and knowing what he was doing, of course. But if you have the gift of being able to evoke the healing response, that probably is the most important thing you're doing. And yes, it is possible. I mean, I think you all might know this, but I came as a skeptic. And maybe I stayed too long, but I am here, as I said, to come in peace and to share the good news, because there's lots that we need to correct from beliefs that we have held, unfortunately, but we held them, and now we have to let them go. And a minor example, but a very prominent example, is this issue of glutathione. So I hope that was a helpful answer to. Oh, very good question. Are there any cell receptors that would allow glutathione to come into the cell? No. Yes, glutathione can interact with the cell, and it is taken apart into the individual amino acids. So when glutathione, or any tripeptide, there are things called peptidases. And what do? They hydrolyze peptides. Anything with 3 or more amino acids, when it touches a cell, will be broken back to 1 or 2. Oh, no. The glutathione cannot get in that way because, no, well, yes. So let's say you use radio-labeled glutathione to begin with. What you find is you get some glutamine in, and that could have been where your tag was, where your label is, where your isotope is. But the glutathione gets broken down into the amino acids, and then those amino acids are slowly reabsorbed up into the cell and can be used to build glutathione in the cell. But my recommendation is start with the precursors. They're less expensive. They are available. We know a bunch about them. But remember magnesium. And a friend of mine wrote a book called First of All, Do No Harm. Second of all, think of magnesium. So if you want your ATP, you need your magnesium. But magnesium is hard to get in, and it tends to run out as fast as it comes in. That's what Mildred Seelig and Bert Altura and Ron Eileen showed. But we happen to solve that problem. So with the combination of magnesium salts and choline citrate, you now make a little tiny nano droplet, a little tiny droplet that is taken up by the neutral pores. And of course, the limiting feature of magnesium has long been that if you give enough to be effective, you get hypermotility in the intestines, the person runs to the commode, doesn't like you, and doesn't really consider that a success. We gave 880 milligrams of elemental magnesium to a phase 1-2 drug trial, because it's that far along. No loosening of stool. We had one constipated person that became less constipated. So we have to think creatively about how to get the precursors in so that the body can physiologically construct what it needs.
All right, thank you, sir. All right, gang, we're all out of time, unfortunately, for the Speakers Forum. So if you would, put your hands together one more time for these gentlemen.